Good evening and welcome everybody who's logged on to join us this evening for our third SRUC webinar. This is the third one of the year, but our first one of lockdown. So I'm really delighted that so many of you have registered to log on, and there are a good number of attendees online live tonight as well. So my name's Helen Carty. I'm one of the SRUC vets based in Ayr, and I'm really pleased that we've got Colin Mason, who's going to be presenting our talk this evening on investigation of neonatal calf losses. Just as in previous webinars that we've run, all of the attendees are on mute, but if you do have any questions, if you could just type them into the questions pane, I'll be keeping an eye on that during Colin's presentation. And if there's any questions I think would be benefit of me interrupting Colin, I'll do so. Otherwise, I'll save them up till the end and we can have a bit of a discussion at the end. We're conscious that it's a Thursday night and that many of you might want to go out to clap the NHS at 8 o'clock. So we'll probably have the slides all run through by about 7:45, leaving a bit of time for discussion, and we'll be wrapped up by 8 o'clock. Okie doke, so without further ado, I will pass us over to Colin.
Okay, thank you very much, Helen. That's great. What I want to do for the next 45 minutes or so is just talk through some of the common causes of neonatal calf death and some of the ways to investigate them, focusing mainly on post-mortem diagnosis, so looking at some of the key features of these diseases seen at post-mortem, to deal with appropriate use of diagnostic tests and how to use those to best effect to confirm a diagnosis if you need to. Clearly in 45 minutes, I'm not going to cover every possible disease combination or option here, just some of the common things. And a lot of the common findings are highly relevant to both dairy and beef suckler systems. So hopefully at this time of year, with a lot of neonatal spring-born beef suckler calves on the ground, this will be a talk of some relevance at the moment, although as the sun shines down outside for another day in probably about a month of glorious dry weather, I think we've been fairly well blessed with a lower incidence of neonatal calf disease this year than perhaps some years. Also, just to say, we had a previous webinar in February on looking at abortions and stillbirth. So I'm not going to talk at all about stillbirths and maybe pick things up just after that time. Okay, so obviously for the suckler herd, any calf loss is a loss, and it's a significant loss and is worthy of investigation. In the dairy situation, not in every dairy herd, but perhaps a slightly higher level of calf mortality is tolerated. But again, every calf loss is a loss, and PM material is fairly readily available at times. They're quite nice, easy PMs to do on farm. So they're the sort of thing that's relatively easy to get stuck into. And very often, like so many things in life, common things are common, but some of the really common things, if they're investigated and pointed out to farmers, can be so useful in terms of changing management, changing different approaches to health planning in order to try and put things right, and sometimes just showing some of the obvious stuff that is going right or obvious stuff that's going wrong with a calf can be really, really helpful in managing situations on the farm. So a little bit of background. I want to maybe pull some information about beef systems and dairy systems. So we'll start with beef sucklers, and what's on the slide here is a summary of work that one of my colleagues, Tim Geraghty, did based up in Aberdeen, and it's a project that's been run by SRUC over the 2 seasons looking at causes of calf loss in suckler herds. So this is based on around about 1,800 suckled calves in Aberdeenshire. And what Tim did is basically followed these pregnant cows through from the point of PD, when you had a confirmed fetus on board, right the way through to how many calves were weaned. And those of you that have been to BCVA over the last couple of years will have heard this talk presented by Tim, and quite a few others might have done as well. But what I want to focus on is not all of these figures, but it goes through where calves are lost. Either the cow dies, the cow aborts, there's a stillbirth, a neonatal calf loss, an older calf loss, and that leaves you with a green total at the bottom, which is the number of calves that were weaned in these 2 studies, which is quite low. but probably also quite realistic for your average suckler enterprise. So focusing on the green boxes, although it's a little bit hard to see, the neonatal losses come in at 1.6% in 2018 and 0.9% of all of the losses in 2019. When you look at the whole scale of losses from basically conception right the way through to weaning. So that's the sort of percentage figures that come out. When you look at some of the individual causes, and there's lots of individual diagnoses here and lots of numbers, but what Tim has done is broken them down really into two categories that will come as no surprise to any of us, in that a lot of the losses in the first week of life relate to colostrum failure as the main driver, and sometimes second to a difficult calving. And then if you move out to neonatal losses to the first month or so of life, in older calves, it's dominated by pneumonia and septicaemia, very often with pneumonia causing bacteria. And we'll focus on some of these causes and some of these diagnoses as we go through the talk. But this is just one study, but it does put a little bit of context into the whole thing. If we switch to the dairy sector and look at some of the background figures for neonatal calf losses, and you look to the literature, there's a range of estimates there. And I think, as we're all aware, the levels of neonatal calf loss in some dairy units can be quite high. So there's a couple of references in the top two bullet points there, based on two different studies that showed up to 12% calf mortality in the first month of life, or an average of 4.5% calf mortality in the 2017 study, but quite a range between farms. And this is being picked up on increasingly, as a lot of you will be aware, by some of the dedicated milk contracts, where they're looking quite a lot of detail at, calf health, calf losses, calf survivability, and that sort of thing. In some of these studies, main causes of mortality, again, no real surprises: diarrhea, respiratory disease, dystocia, rumen, bloat, etc., etc. So again, we'll cover some of these as the talk goes on. And coming from the Bricknell study is an estimate based on clinical scoring that roughly half of all calves on the study had an episode of pre-weaning calf diarrhea, and half had an episode of pre-weaning pneumonia. So lots of potential disease there to go at and see what's going on. Not that all those calves died, of course. So maybe starting at the beginning, I just wanted to focus, coming back to the suckler calf stuff. A lot of the losses relate to colostral transfer, failure of passive transfer, and perhaps some of the most important testing that one can do in any of these calves is to assess colostral absorption and the degree of passive transfer of immunity that's gone on. As we all know, when we're thinking about calf immunity, calves are born a gamma globulonemic. They have a poorly developed cell-mediated immunity at that stage. And also in the immediate postpartum period, they've got a high level of cortisol in the system because of the stresses and strains of being born and adapting to the first few days of life. So there is, as we all know, plenty of potential there for a suboptimal immune system, if you put it that way. So assessing failure of passive transfer is critical in calves. Up to a week or 10 days old is a really useful diagnostic test to do at post-mortem, and it can be done. So as long as we're not dealing with a really, really autolyzed carcass, it's possible to harvest some fresh blood from a carcass fairly easily, usually as you're opening it up, and that can be used either for total protein or ZST estimation. And can give you a bit of information about that particular calf, and it will be relevant for that calf and may well be relevant for the farm situation as well. And it's particularly useful to consider that diagnosis in relation to early life septicemias, because obviously a low colostrum status, a low immunity is part of that syndrome. Obviously, a PM case will just be one, and assessing a cohort of calves under a week old, blood sampling those to look at total protein levels is a useful thing to do to support this diagnostics as well. But that's all I really wanted to say on that one just now. It's maybe worthwhile just putting in this slide. We've put this slide out numerous times on the hoops, and it's a really interesting piece of work that comes from Canada, and it looks from a clinical setting at the prediction of failure of passive transfer based on assessing the suck reflex in calves less than 4 hours old. And really what they did is that they grouped calves into calves that had an unassisted calving, calves that had an easy pull, and calves that had a difficult calving, and they looked at the suckle reflex of these. And I think the figures here are really quite striking, in that if they have a weak suckle reflex within the first 4 hours of life, then their chances of failure of passive transfer are really quite high, ranging between 78% right up to 98%. And that's quite marked. But even with a strong suckle reflex, when you work it down through the range of severities of calving that occur, then the chances of getting a good absorption of colostral antibody drops quite markedly, and it does really highlight that combination between the quality of the suck reflex, which is a good predictor, but also the fact that difficult calvings, even if there is a good suck reflex, there may be problems with colostral absorption that may be related to acidosis as the calf is born. So it's quite a good clinical check that can be done. Obviously, there are quite a lot of sequels to a failure of passive transfer, and these are all of the common things that we're very well aware of as vets and as clinicians. So the slide here shows the sequelae of a navel ill with infection tracking up to the liver, and I'll come back to navel ill in a second. With or without navel ill, there is the possibilities of an neonatal septicemia and bacteremia. So you can see in this slide here, which is associated with the navel ill, the loops of small intestine that are sort of meshed together with fibrin, and a lot of turbid abdominal fluid there as well. So the possibilities of an associated peritonitis, you sometimes see those with E. coli septicemias. Meningitis is, again, it's always in talks like this that you put in the really nice slides with the really obvious cases, but they do occur really quite severely when you open up and look at the brain. Sometimes you do get these very, very severe meningitis. Sometimes it's a lot more subtle than that, with just a level of clouding on the surface of the brain that you see, but very much part of the syndrome. And joint ills as well, in maybe more advanced cases. So we'd all recognize clinically the sort of septicemia, navel ill, meningitis, joint ill type of syndrome as quite a common cause of calf loss in the first week to 10 days of life, very often associated with the failure of passive transfer. Defining a septicemia, if we're wanting to do lab testing to look at this, I guess firstly what we've got to bear in mind is that some of the signs of these septicemias can be far more subtle than the pictures I've just shown. So levels of petechiation, for example, hemorrhage, maybe some of the more subtle signs that you might see in carcasses, as you can see in the brain and the cranium of this particular case. The way we would define a septicemia is a pure growth, or certainly a significant growth, of the same bacterial organism from 2 or more tissues. So really, to define a septicemia, bacteremia, you need at least a couple of tissues where we're getting the same organism back. Very often it's E. coli as the cause, and again, what we found over the years perhaps is some of these E. colis have had quite variable antibiotic sensitivity patterns, which sometimes relate to what's been used on the farm and preventative strategies that have been used on the farm. So these AST patterns can be quite interesting and can be really quite relevant if these are sudden death calves that have not been treated in any way. So getting an isolate, getting an antibiotic sensitivity can be quite useful in terms of getting the correct antibiotic and appropriate use of antibiotics in these cases. E. coli obviously is not the only cause, and other bacteria will be there. of which perhaps the other common two that we might see will be the Salmonella and Pasteurella species, occasionally causing septicemias in young calves. And that's not an exclusive list by any manner of means either, but it's always good to know what it is, what is best to treat it with, and how to focus that going forward. Next slide does show what we see occasionally in Salmonella Dublin septicemias is they don't all present like this, but occasionally you get them with a very enlarged rounded liver, severe carcass jaundice, and highly suggestive that this might be a Salmonella Dublin septicemia. Obviously copper toxicity might be another potential etiology if you see a case like this, but they're quite marked when you do see them. Okay, so that's a little bit looking at failure to passive transfer, bacteremias, septicemias, etc. Again, it's worthwhile just mentioning navels and navel ill. Again, really common problem, and can certainly be assessed clinically as well. But it's a very good educational tool for farmers in terms of on-farm postmortems and what it can show and how it could perhaps change management and behavior on farms. So, this would be quite a good example here where you've got the tip of the navel that's in my hand, which is quite crisp and quite dry. When you actually go to the umbilicus itself, you can see that the navel there looks a little bit more damp, and it's not dried up properly, and you can also see there's plenty of iodine on the body wall of the calf as well. And then when you cut into that, under my finger there, you can see some of the infection tracking up, and quite a nice internal navel ill there, which would not necessarily have been completely evident from a clinical examination. And that's really the point, I guess, is that sometimes they can look pretty normal externally, and yet internally there is an issue there in terms of infection, either tracking back towards the bladder or up towards the liver. So again, it's not an earth-shatteringly new and emerging condition, but it's really common and it's really important, and it's a good way of proving to farmers and investigating these things a little bit further. Looking into the literature on navel ill and scoring systems for this was some work that was published 2-3 years ago now, and it looked at a population of calves that was submitted at an abattoir, and I guess probably young calves being sent to an abattoir, possibly quite an interesting collection of calves to look at, and nearly just over a third of them had evidence of navel ill at post-mortem, and some of the obvious signs that were predictors are listed in this slide. So a thickening of the umbilical stump greater than 1.3 centimeters, discharge, a raised local temperature around that area, and herniation in the umbilicus were all positive predictors, and just puts a few figures around it in terms of some of the clinical scoring that might be able to be done. The slide here is of an older calf with an advanced chronic navel ill, and you can see the picture on the left just shows the thickness and the levels of fibrosis that there is in this navel, and then the fact that infection has tracked up to the liver, so you've got liver abscesses there in the picture on the right with a good zone of fibrosis around about it, and I would say every year we'll see suckle calves that really have done remarkably well up to maybe a couple of months of age, sometimes even older. So they've really got past the neonatal calf disease stage of life, and then they die suddenly. And they cause quite a bit of alarm to the farmer as sudden deaths at that stage. And yet, when you actually do the post-mortem on these cases, it is still relating back to a navel ill, and I'm guessing it's either because there's eventually been liver failure or there's been abscess rupture and localized peritonitis, but that calf has coped remarkably well, grown remarkably well for 1, 2, 3 months of its life, and then suddenly failed as a result of the navel ill that it probably picked up in the first 24 hours of life. So it can still present as problems further down the line, and I would say we always see a case or two of this every year. Okay, so moving on a little bit, I want to just pick out a few figures from some work that one of my colleagues, Katrina Henderson, did. And what she did is reviewed all of our diagnoses of pre-weaning mortality in dairy calves. So just flipping it over to some of the facts and figures for dairy calves, which is quite interesting. And what Katrina did was looked at all of the diagnostic data that we had between January 2014 and December 2018 for dairy calves in the neonatal period pre-weaning. Looked at the history, looked at the causes of death, and picked this up. It was all passive surveillance data. So this data obviously has limitations in terms of the fact that it's carcasses that were submitted to a VI centre for examination. But at the same time, there was quite a number of them. So there was 614 calves identified. There was a really high diagnostic rate in these PMs, which should hopefully enthuse us to keep going with them. And a high number of diagnoses were made. So there was over 1,000 diagnoses were made. Nearly 70% of these were infectious, but a significant chunk of them, 25%, were nutritional, and we'll come on to that a little bit more in a second. So these are some of the facts or figures. These are the biggest single causes of diagnosed causes of neonatal calf death up to weaning in dairy calves. And some of the things on there would be exactly what you'd expect to find. So Cryptosporidia, rotavirus, naval ills, septicaemia, Salmonella Dublin, which I've already talked about, highlighted in red, and some of the pneumonias as well. And we'll maybe talk through some of these over the next few minutes and in the next few slides, just in terms of what you might see and how you might make a diagnosis. But one thing that's maybe come out as interesting is the number of cases of rumen drinking that are in there, and I'll come on to that in a second in relation to dairy calves. And also just to say that although this was a dairy calf survey and a review of dairy calf data, clearly a lot of these diagnoses, if not all these diagnoses, possibly with the exception of rumen drinking, relate equally to suckle calves. A calf is a calf, and therefore from a disease investigation point of view and from a pathology point of view, it's equally applicable to either a dairy or a suckled beef calf. So if we think first about the enteric diagnoses, these were the main ones there. So again, usual neonatal enteritis pathogens as you expect, coming in fairly high. Salmonellas rate fairly highly in our area, in that Salmonella Dublin is particularly common, and some of the other Salmonellas appear there as well. AEEC is attaching and effacing E. coli infection, which is a particular pathological diagnosis, I suppose, or even histopathological diagnosis, where it's E. coli strains that do exactly as the name describes, in that they attach to the villus and they basically efface the lining of the mucosal surface in those areas, so that they cause villus stunting, and it's a histopath diagnosis whereby you can see the organisms fringing the villi, causing this particular syndrome. So it can be quite a difficult one to get, and certainly it's the only diagnosis that you can only make it on post-mortem. But it's probably something that's underdiagnosed as an E. coli cause of neonatal scour. So we'll pick out some of these things as we go, and just thinking of the general features of looking at enteric disease in calves. Obviously, looking at the levels of dehydration to start off with is particularly relevant. Clearly, you can't assess it in the same way as you would in a live animal, but the degree of sinking of the eye can be quite severe, and given that these are animals that have died, the levels of dehydration can be quite marked in some cases. Similarly, also, you'll get scour cases where you don't see that, and although it's hard to test post-mortem, I often suspect that it's the acidosis element rather than the dehydration element that might kill some of these, particularly in cases where you might have rumen drinking, or you may have a hindgut fermentation going on with an excess of acid production. So you may or may not see sinking of the eyes. So looking at the intestinal tract and where do we start in all of this, and how do we make a diagnosis? And I always think for practitioners or vets starting work doing pathology, looking at guts and looking at gut pathology is really difficult because how do you distinguish between what is real pathology and what is post-mortem change? And post-mortem change starts to occur fairly early in intestines. And one of the general bits of thinking is by the time you get to sort of 20 minutes, half an hour after the animal's died, you're starting to get quite significant autolytic damage starting to occur just because of the levels of organisms that there are present in the gut. So interpretation is key, and it can be quite tricky to do sometimes. In terms of sampling, obviously what we've got to bear in mind with the neonatal enteritis pathogens is that they can be present in diseased animals, and they can also be present in normal animals as well. So there's two levels of sampling. One is to detect what agents are there, and then if possible to try and ascribe significance to them or not, which you can do at post-mortem. So things to be aware of there. Just looking at this, so where I would normally go and collect gut contents from is from the cecum, and also maybe further down in the colon as well, just trying to capture from a couple of areas of the gut to try and pick up material to hopefully identify pathogens that were there. And that can be used for neonatal enteritis testing. It can be used with a lot of the kits that you have in practice, or could be submitted to a diagnostic lab for testing. So intestinal content, where I would normally go for culture for looking for bacterial pathogens is a piece of ileum, and collect that. And really, what we've always got to bear in mind, as I've already alluded to, is this, this presence of entropathogens versus disease, and that you'll detect pathogens because they're very common, and it's trying to relate that to the disease process that's there. In terms of histopathology, it can be useful, and if you've got an animal that is very acutely dead or is freshly dead, or if it's one that you've euthanized on farm because it was dying or non-viable, then these are the ones that are so useful from a gut histopathology point of view. So I would always urge, if you're in a situation on farm where you're struggling to get to the bottom of what's causing neonatal enteritis problems, and a diagnosis is important for you and for the farmer, then if you get the opportunity with a moribund calf to put it to sleep and then harvest gut material straight away into formalin, then that stuff is incredibly useful, and is often something that we struggle to do in VI centres unless we get live calves in, which we certainly can do as well. So I would tend, when I'm collecting tissues for histopathology, to work my way from ileum back up the way, and section the ileum. I would always section 5 or 6 different levels of the jejunum right the way up to the duodenum, and then get 2 or 3 sections down into the colon as well, so that you're getting the full range of tissues right the way through the tract, and also to fix any areas where you think there might be pathology there based on the gross findings. So that's the way I would play it. I would also get sections of the abomasum and the forestomachs if I thought it was relevant, and then go from there. One other thing to mention at this point as well is specific cultures for Salmonella, if that's a possible differential, in that certainly the ileum is a good place to find it, but also liver, including gallbladder, and potentially bone marrow are good places to go looking for Salmonella, particularly if it's been treated, because very often if we look quite hard for it, we can still find it even in treated cases. So the dilemmas of gross pathology and post-mortem change, so looking at pieces of gut section like this, where you've got darkened areas as well as lighter areas, it can be very hard to tease out the the areas where it looks a bit more reddened, a bit more hemorrhagic, is that post-mortem change or is that significant pathology? And very often in these subtle areas of change, it can be post-mortem change if the animal is not freshly dead. So we've got to bear that in mind. And again, if in doubt, then potentially consider histopathology as something to go for. I always find it perhaps easier in these talks to look at some of the intestinal changes where you do get pathology and compare those to the ones where you don't. And then you can see, sometimes when it's obvious, and it's easier to find. So in coccidiosis cases like this, for example, thickening and reddening of the intestinal wall. And maybe just a quick mention of coccidiosis as we go, just while I'm talking about it. It just about shoehorns itself into the neonatal calf diseases. We can start to see coccidiosis cases from 4 or 5 weeks of age with Iberia alabamensis, which is one of the pathogenic species. The pre-patent period is actually slightly shorter, so potentially you can pick those up after a pre-patent period of 2 to 3 weeks rather than 3 weeks. But there's 3 pathogenic species that are highlighted there. And just one thing to flag in terms of the age distribution of these things, these diagnoses. One of my colleagues, Heather Stevenson, put together a review of these and compared cocci diagnosis in suckler herds versus dairy herds. And what we tend to see in the suckler herds, as we'd expect, is quite a distinct peak in coccidiosis between 5 and 8 weeks of age, as these calves start to eat a little bit more grass, become more susceptible, and there's quite a marked peak there. Whereas in the dairy calves, what we tend to see is possibly lower oocyst output, first and foremost, and a much wider age range in which we see the infections occurring, probably reflecting in the dairy herds a more gradual exposure to the parasite depending on the state of the housing and what's going on there. So the disease presentations can be slightly different. We tend to see more of the acute melenic bloody scour with straining cases in suckler herds, and maybe more of the chronic scour and ill thrift cases in the dairy herds. But we can see either in either system, if I'm being honest. Going to other more severe pathology that we will see in intestine in neonatal calves. So we will see these necrotic type enteritises, and again, when you see them, there's no disputing them, as can be shown here with significant necrotic damage, in this case to the small intestine, which was associated with a Salmonella infection. And moving on to the next slide, sometimes the Salmonella Dublin infections that we do see, not all Salmonella Dublin cases will present like this, I would hasten to add, but on occasion some do, and you can see without even looking at these intestines, looking at the serosal surface, that there's obvious intestinal wall thickening, slight adhesions between the different loops of the jejunum there, and when you're looking at the cut surface, you can see the level of thickening, the level of ridging that there is on the intestinal wall in that particular case, and we will see that from time to time. So it does show you that from time to time you will see quite marked intestinal pathology, in contrast to perhaps some of the more subtle lesions, or indeed some of the post-mortem change that you might see, and where histopath diagnosis might be needed in some cases where we're not really seeing any obvious gross pathology. Okay, so one of the things that did come out of the survey of the neonatal calf deaths in the dairy is that nutritional causes feature quite highly, and 26% of calves had a nutritional component to it, which was, I think, a surprise to all of us when we picked this out. And the sort of things that we were seeing was rumen drinking with a secondary acidosis and a rumentitis. Sometimes these were fungal rumenitises. We would see abomasitis, ulcerations and bloats, and then perhaps secondary to that, aspiration pneumonias and stunting and poor-grown calves. And again, some quick things to look at when we're looking at neonatal calves. One of the really nice obvious things to look at, and again, it starts some good conversations with the farmers about what's going on, is what's going on in the abomasum. Do we have an abomasal milk clot or not? and that may relate to the type of milk powder that the calf's being fed. So if it's being fed a skimmed milk powder, if it's a dairy calf, then you would expect an abomasal milk clot to be there. If it's being fed a whey-based milk powder, then you wouldn't. And obviously, if it's a suckle calf sucking its mum's milk, then you would expect a good abomasal milk clot to be there. So again, knowing that and knowing what you find can instantly open up some conversations with a farmer about how milk is being fed if the calves are being artificially reared. Similarly, looking at the degree of rumen drinking and the amount of milk that's ending up in the rumen is really quite a relevant conversation in relation to how calves are fed. This is obviously not infectious disease. This relates to feeding practices, acidosis, esophageal groove function, etc., etc. So here's a rudimentary rumen in a very young calf with some evidence of rumentitis and milk building up in the rumen, and then you get that through to the really severe, really quite smelly and horrible rumen drinkers, where you have a lot of milk starting to collect in the rumen, starting to try and clot. The calf is also fermenting that, so there's a major acid load, and this in its own right can be a cause of death in these calves. And looking at some of the risk factors, again, it depends on feeding practices, but if calves are fed from a bucket rather than a teat, if they're fed low volumes of milk, and also potentially if they're fed waste milk, which they shouldn't be, but if they are, then these may well be risk factors for rumen drinking that we see. So it's not an insignificant cause, and there are these sequelae to it. So you can see in the picture on this slide, there's evidence of rumentitis in this calf as a secondary complication to the acidosis and the fermentation of the milk within the rumen, which will cause chronic bloats. It will cause chronic scours, malnourishment, and potentially also death. The bottom point is a diagnosis of dysbiosis, which is, I think, something that we see and recognize more commonly. It's in relation to changes to the microbiome within the gut itself. And obviously we look as clinicians and as diagnostic vets, we look very simplistically sometimes at the causes of calf scour, and we say, oh, well, it's got to be crypto or it's got to be roto or whatever. But of course, these are sometimes the trigger factors, and what happens as a result of that is a massive change in intestinal flora that can have a marked effect on the outcome as far as the calf is concerned as well. Quick mention of abomasal ulceration. We'll see it as an incidental finding, and we'll see it as a significant cause of death, usually in sporadic cases, obviously in relation to acid loading. And there is a syndrome that we do see at post-mortem, both in suckle calves and also dairy calves, of an abomasitis, abomasal bloat, ulceration, and rupture type of syndrome, possibly in relation to how the calves are fed. Sometimes you'll see it in association with a Sarsinia infection that can be picked up histologically as well. But we do recognize this as a cause of sporadic death, and we'll also pick it up as an incidental finding in some of these calves. Now, I'm conscious of time, and just moving on to some of the other pneumonia diagnoses that were made as part of this dairy study, and you can see the breakdown of these here. And again, a lot of them fall into the bacterial category. And of note, Salmonella Dublin is on there as a cause of pneumonia, which we see quite commonly, and the viral causes are also there, but less compared to the bacterial causes in neonatal calves. So at this time of night, you'd be glad to know I'm not going to go through every cause of pneumonia, and I think what we've got scheduled later on in the year is a webinar on investigating respiratory disease, and we'll cover quite a lot more of this in more detail at that stage. But I just wanted to pick out a few things that are relevant to neonatal calves just to finish off with. The first is just to make mention of IBR. In the diagnosis of the respiratory form of IBR in neonatal calves is a very rare occurrence, and probably, I would never say never, but a very, very rare occurrence. And what I would say is that if particularly the dams are vaccinated for IBR and there is good colostral immunity, for bovine herpes virus 1 passing through to the calf, then the chances of the calf developing an IBR, a BOHV1 associated pneumonia in the neonatal stage is much lower, and it's only when that neonatal immunity starts to wear off that the risks for that calf might rise. However, there is a specific syndrome in relation to IBR that we do see occasionally, and it's quite a unique set of circumstances in the calves themselves would have to be naive to the virus, as in the dams would not be passing any on any colostral immunity. So the dams would be seronegative, and the non-vaccinated. So the calves are born naive, and the dam will be likely to be naive. And then for whatever reason, IBR virus then gets into that calf rearing unit, whether that's a suckle calf or a dairy calf. And in that particular set of circumstances, the virus can really have a bit of a field day and cause quite high mortality. And the sort of things that will be seen at post-mortem can include diarrhea, they can include pneumonia, they can include laryngitis, tracheitis, occasionally encephalitis, liver necrosis, and very often these things will present as sudden deaths. So it's just an interesting one to point out. If the herd history is right, where we've tended to see this syndrome is in scenarios where cattle have been imported and they've come in possibly from abroad, from IBR-free countries. So they've come in non-vaccinated and naive, and then they've joined an endemic herd situation in a herd in the UK, and then that creates this scenario where this can occur. But it would always be in the back of my mind if we were seeing a high mortality outbreak of disease in young calves, and the history fitted the picture, it would always be there. And it's quite an easy one to diagnose in that, as I say, the virus has a field day, so it's quite easy to identify BOHV1 by PCR on a range of tissues, not just lung, from these sorts of calves. So what I wanted just to finish with is say I'm not going to go through all the pneumonias, but that's say just to focus on how to maybe go about investigating these things from an on-farm post-mortem perspective. So a lot of the pneumonias that we'll see in young calves, whether they be suckler or whether it be dairy, will be the sort of type of pathology that you see in this picture, with an antroventral lung consolidation, likely airborne pathogen transmission, and that will be a typical picture that we would see. Some people might be better than me, but I can't tell by looking at that what the causes of pneumonia are. It's an airborne pathogen and it's definitely pneumonia, but beyond that, from a gross pathology point of view, just looking at that, it's hard to say what combination of organisms have been involved. So to get a feel of it, if you're doing on-farm postmortems, and what we would really like to get from our point of view to help with the diagnoses is if we can get some photographs, really helpful. So if we can get a dorsoventral view and we can get a lateral view of the lungs, it helps us hugely in terms of looking at the overall pathology and relating any material that you might send in to what you're seeing in the lungs overall. It's really helpful for us. It's really helpful for any histopathology that's done as well. So that will be the first thing to say. And this is a suggested sampling strategy for first-line sampling to look at the range of possible pathogens that might be there. So I've set this out based on a culture and a PCR approach, and I'm aware that depending on what labs you're using, then there are multiplex PCRs available that will pick up both viral and bacterial causes. But really, as an approach, getting some lung tissue or a charcoal swab of lung tissue to do routine cultures and to look for H. somni. A plain swab with mycoplasma transport medium to pick up mycoplasma species, really useful. And in terms of areas to sample, if you get a consolidated piece of lung to sample close to an area that perhaps you're going to sample for a histopathology as well, then you can associate the findings quite nicely. A piece of lung into virus transport medium for looking for respiratory viruses, really, really useful. And again, as a general approach, and I'll show you a picture of this in a second, an advancing lesion is the place to look for those. And if there's any evidence of tracheitis, which really there shouldn't be, less common in neonatal calves, but if there is, then a piece of lung or a swab of the lung for BOHV1 PCR is useful. Again, if we're looking for sampling sites for histopathology, then the advancing edge of the lesion tends to be the place to go, just to try and pick up any new pathology that's occurring there. And we would always go for histopathology as a second line of diagnostics, and as a suggested strategy for what to look at is a piece of cranial, cardiac, and diaphragmatic lobes from one side of the lung. So you've got a range of lung tissue there. Get some normal and some abnormal tissue, and get the advancing lesion. And that way you've got a broader spectrum of the tissues that are there, which in combination with maybe a quick photograph of what you're seeing, really, really useful to help guide a diagnosis. Additional testing that might be needed depending on the case would be to consider the possibility of BVD infection. Depend on farm history and situation, but depending on the quality of the carcass and the age of the animal, that could be done on a blood sample if it is a freshly dead animal, or spleen in virus transport medium is a way of identifying virus if it's there. Looking at sternum is quite a useful tissue to look at, and fixing a piece of sternum so that we get the bone marrow. If there's any evidence of hemorrhagic disease, then that's a really, really useful tissue to collect. And we used to do this quite frequently when we were seeing a lot of the bleeding calf cases coming through the post-mortem room a number of years ago. We don't see as many of those now, but any case of hemorrhagic disease, if they're occurring, then looking at sternum is useful. And as I've already said before, there's a wider range of bacteriology samples that might be required if you're wanting to consider salmonellosis, particularly if the animal's been treated. Okay, so I've got to 7:45, which is what I wanted to do. I would just acknowledge all my colleagues, but in particular Katrina Henderson, Heather Stevenson, Megan Ferguson, Helen Carty, and Tim Geraghty, who have all contributed to some of the slides, or a good chunk of the slides in this presentation. So it's not just my stuff, it's a group effort, all of this, and we're supported in the work that we do by the Scottish Government. So thank you very much.
Brilliant, Colin. Thank you very much for that. I know it's a difficult task to cover so much in 45 minutes, but you're spot on with time. Fortunately, we've got a bit of time for some questions, and we've got some questions that have already come in. So one of the first questions that's come in is just going back to your slides to do with Salmonella and Cocci, and somebody was asking if there's not, if the intestinal content is not bloody, would you still consider Salmonella or Cocci to be a possibility, or can you kind of rule that out?
No, I don't think you can rule it out, in that, yes, a hemorrhagic scour is one of the features of both of those diseases, but that doesn't have to be the case. So we'll see salmonellas where we don't see a hemorrhagic scour. So we would always be screening these cases for salmonella anyway, and certainly wouldn't get all of them with a hemorrhagic scour. Similarly, coccidiosis, the really severe ones, and that peak of cases that you see in the suckler herd between 5 to 10 weeks of age or thereabouts, very often those are the ones with a hemorrhagic scour and a really, 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 really high coccidiosis count. And those are the classic textbook cases of coccidiosis, I would say, which clinically will be a hemorrhagic scour with tenesmus and a calf that is anemic potentially. But we very often see lower grade coccidioses, particularly in dairy calves, where the coccidiosis output can be quite low. So, in an acute bloody scour, you might see coccidiosis output in the tens, hundreds of thousands of oocysts potentially, whereas in some of these chronic cases where you've got that battle, if you like, between repeat infections and developing intestinal immunity in the calf, and you'll see oocyst output being quite low. Feces will be liquid or pasty, won't necessarily be hemorrhagic, and the calf, may just be ill-thriven rather than totally diarrheic.
That's great, thank you very much. The next question we've got is to do with kidneys. Do we see kidney infections in calves?
You can, absolutely you can. So I suppose going to the the bacteremia, septicemia type syndrome, you can definitely see that can involve the renal system, and you can see evidence of pathology there. The secondary to navel ill, you occasionally get abscesses there, so you can definitely see that. I'm never quite sure, but one of the things that I think we see quite commonly is you'll see the renal cortices quite pale in some of these dehydrated calves. So that's sometimes a secondary finding that you will see in these calves. And then we do see sometimes in sort of 4 to 10 week old calves, you'll see this condition called white spotted kidney, which I think Megan had a slide of this in the first webinar that we did. It's exactly as it says, in that it's a kidney that's covered in white spots, and the pathology is quite marked, although it very often is an incidental finding in these kidneys secondary to a previous episode of septicemia, bacteremia, and it will be focal damage because of bacterial proliferation and toxemia.
Great. Another question we've got is to do with ruminal drinking, and if milk is found in the rumen, is that likely to be the cause of death, or should we still look further and collect other samples?
I would definitely always look further, in that it depends very much on circumstance. So we will see rumen drinking quite commonly as a finding at post-mortem. It may not be the cause of death, although you could consider, I think, when you see some of the pictures that are in this presentation, that in these very severe cases it would have been. But it very often will be a contributory factor to it, in that there may be another cause of scour, there may be another an episode of pneumonia or an issue there. So there could well be other things going on, but then you get the rumen drinking as well. And the acidosis that generates may be the final straw. I think there's two things to say. One is that finding is always an interesting one in terms of how you can then relate that back to what's going on farm and how you discuss things with your client. So it's a really good one to open a conversation with the farmer. And the second thing, I suppose, is when you're looking at post-mortem, you never quite know the time order in which these different things occurred. So did the rumen drinking start first, and then the calf got ill with a pneumonia, and then did it die? Or did it get ill with a pneumonia first, or a scour, and then as it got more ill, did it start rumen drinking as a result of that? You never quite know the order in which it occurred, but I would say it's always a feature of one of the contributory factors, part of the syndrome that's occurring in terms of what killed that calf.
And a similar question has come in just to do with whether is any milk in the rumen abnormal, or could milk spill into the rumen sort of post-mortem?
Yeah, and that's quite an interesting one. So, well, milk could spill into the rumen post-mortem. That's a possibility. It depends how the calf's fed as well, because if you overwhelm the esophageal groove capacity of a calf, then you will get some overspill into the rumen, and then that milk will work its way down through into the abomasum. So it will work its way down in that way. But really, milk shouldn't be there, and we see plenty of calves post-mortem where there's absolutely no milk there. Also, you quite quickly can see some whitening of the ruminal mucosa sometimes, and the starts of evidence of rumentitis. So again, to distinguish between those two things, you might see milk there. You may also see starts of some rumentitis starting to form, and certainly when you see that, then it's definitely part of the problem, part of the syndrome, and it's been there for a while.
Graham, we've got a couple more questions here. If anybody else has got questions, if you want to just type them into the box, we've still got a few more minutes. One question that's come in is to do with pneumonia cases, and if the calf has had antibiotics prior to death, is there any point in taking swabs for bacteriology?
Yeah, and that's a very good question. So over the years, certainly with the culture techniques, what we have found is a lot of the pneumonia the common antibiotics that are used for pneumonia are highly effective in that it is quite a common finding that you will get dramatic pathology, and it's been treated with whatever drug, and you know, the lungs are sterile. So we do see that. It may be a situation where PCR is more useful in that you could potentially still pick up DNA from those cases. So it might be a situation where that's still useful. But I would always say that I would give it a go. And certainly in our situation, we would, if you're thinking of something like Salmonella and sometimes the Pasteurelli, we will find it, even in spite of antibiotic treatment. So it's a hard one to answer. It's one of these things, I think, if nothing ventured, nothing gained. And you've got the differentials between, you know, whether using culture techniques or whether using PCR. And certainly what we found when we're looking for Salmonella, if you increase your sample set, not only lung, but look at that range of tissues that we highlighted, including liver, bone marrow, gut, and just widening the sample set, it's quite often you will find it there with enrichment techniques. So it's worth looking out for.
Grand, we've just got another couple of questions. They're kind of to do with trying to figure out whether findings are significant or not. And so one of them is, can you tell if aspiration of milk is significant?
From a histopath point of view, it will be possible to have a look at that. So it is conceivable that you might see that at gross post-mortem, and you might see milk in the airways. And one of the questions straight away is, well, has that occurred just as that calf died, or has it occurred after that calf has died? And both are possible. But if there is, an associated hemorrhage or inflammation with it that you can see, then that might be relevant, and you can certainly pick up the relevance of those changes if you look at some of the suspect lung histologically. So an aspiration pneumonia, yes, it can be terminal, yes, it could be potentially post-mortem change, but you can tease that out using histopathology if we think it's needed.
Great. And just the last question I've got, unless anybody else types anything else in, is you mentioned that the abomasal ulceration on the picture that you put up, that could be incidental. Can that be a normal thing, or does it always reflect an underlying issue?
It's a hard one to answer that, in that we just don't.
You've got 1 minute.
Because we just don't know the level to which this is going on in perfectly normal calves. And I suspect it is. In that I suspect if you think of the levels of stress that some calves are under, if you think of some of the calf rearing systems now where calves are moved around, there's lots of potential risk factors for that occurring. So I suspect there's quite a lot that slip under the radar as calves that are normal, and they have some degree of abomasal ulceration in the same way, I suppose, that occurs in humans as well. But then we are only going to see the severe ones where you get a melena, and you can see those clinically, obviously, before they die or where they die. And we are only going to scratch the surface of those, I think.
Great. Well, I think that's perfect timing, Colin. Thank you very much for your really comprehensive overview on neonatal calf losses, and thank you everybody. There was 36 attendees this evening, so that's ideal, and more people can access the recording at a later date when it suits them. So thank you very much, everybody. Have an enjoyable rest of your evening, and go and get your pots and pans to go out and clap for the NHS. Okay, thanks everyone. Bye for now.
Bye bye.